Dr. Benny Negalur. First, let me thank the organizing committee of RSSDI and Wochkardt for this presentation. My topic is managing diabetes before pregnancy and during lactation. So any woman of reproductive age who is not taking reliable contraception may become pregnant. And this reproductive age can be anywhere between menarche to menopause, that is between the age of 15 to 51. And study has shown that only 26% of the women with diabetes have planned pregnancy, which means there's a large number, 75% of them, their pregnancies are not planned. Therefore, pre-gestational diabetes is on the rise. On the one hand, the childbearing age has gone up because women are delivering babies in the late 20s and early 30s. And on the other hand, the onset of diabetes is seen in younger and younger women and younger individuals. And therefore, pre-gestational diabetes is a big problem. In addition to that, there is physical activity and obesity, which adds to the complication. Pre-diabetes complicates 1 to 2 pregnancies of all pregnancies, and 13 to 21% of diabetes in pregnancy is pre-gestational. We need to look at pre-gestational diabetes because the glycemic control is the single most influential factor for embryonic development. And if there is glycemia at the time of conception, then it can give rise to fetal and maternal complications, give rise to congenital malformations. The ideal A1C is between 6.5 to 7. And the higher the A1C, the higher is the risk of complications. So there could be fetal complications like congenital abnormalities, spina bifida, sacral agenesis, anencephaly, fetal cardiac anomalies. There could also be hydramnios, stillbirth, increased neonatal and perinatal mortality, neonatal hypoglycemia. And in the mother, there could be ketoacidosis, miscarriages, abortions, preeclampsia, and increase in the cesarean rate. Therefore, it is important to plan the pregnancy and also give preconception care, advice, and information to women who are diabetic and are likely to get pregnant, starting from adolescence. So we need to inform them about the role of diet, exercise, and also pre-gestational weight. If the weight is high, then the complications are higher in pregnancy. We need to review their medication, take them off. All the OHAs have to be discontinued. Only metformin has been shown to produce no harm, but the ideal drug is to put them on insulin and maintain their glycemia with insulin only. We need to explain them about effective monitoring to prevent the hypoglycemia, because hypoglycemia can be detrimental both to the fetus and the mother. You need to give them folic acid, 5 milligrams per day, at least 3 months prior to conception, and continue that about 12 weeks after conception. And we need to explain to them the risk of large gestational age babies and neonatal hypoglycemia. And so they should be aware of all these complications that can happen. At the same time, there has to be effective screening of the complications pre-gestationally. One is retina. Retinopathy can worsen during pregnancy, and therefore a dilated eye examination is mandatory in the planning stage. We need to also screen them for nephropathy, look at the microalbuminuria and also the creatinine. If it is about 1.5, a reference to the nephrologist is important. Gastroparesis, which is part of autonomic neuropathy, can complicate pregnancy, can give rise to hyperemesis, can also produce dysglycemia due to erratic absorption of the nutrients. And if the woman has cardiac disease in the prior to conception, then it is important that cardiac care, ECG, and echocardiogram is important to assess the cardiac status. Hypertension, if they are already on drugs, you need to take off their ACE and ARBs and put them on either methyldopa or labetalol, which is a drug of choice, and also nifedipine, etc. So the ideal candidate would be a well-controlled woman, diabetic woman with no wide swings of sugar, a normal HbA1c, absence of vascular disease, preconception folic acid has to be taken, normal renal function, and the ability and willingness to closely monitor the blood glucose. Once the delivery is over, we need to continue insulin in the postpartum stage and during lactation. But metformin is also shown to do no harm during lactation because the amount of metformin in the milk is very small. Need to continue the monitoring and also maintain the targets of an HbA1c less than 7 in the lactating stage. So in summary, pre-planning, pre-gestational planning is mandatory, starting from puberty and continuing in all women with diabetes, reproductive potential. Pre-conception counseling should be incorporated in their routine diabetic care, optimize their blood glucose, and screen them for all complications. Thank you.